Good morning. It's a pleasure to see everyone here today. And one of the things I wanted to kind of point out is, why is a surgeon uh, building and putting together this Center for Elementary and Metabolic Science? A little bit of a strange uh, a strange idea, but it's because through my training and now with my colleagues here, you know, I became interested in obesity when it was actually not a cool thing. Like people say, why in the world are you going to work in obesity? This is sort of in the mid 90s. And I think over the years, we've been able to build a vision of really doing what a lot of folks profess to do, which is bedside to bench to bedside. So you heard my wonderful colleagues, Dr. Cummings and Dr. Adams, already talking this morning about, sort of where we go from this. And I'll talk about that in a second. But really what I want to point out to everyone is that obesity is a chronic, progressive, relapsing disease. And everybody's going to nod. No, I really mean it. It's not about the behavior of someone who is choosing to do one thing or another. And I take it back to the Fowler effect. And if you've never heard of the Fowler effect, it's because I made it up. Brian Fowler was my roommate in medical school. And Brian lived however the hell he wanted to live and never gained an ounce. Not a pound, but never gained an ounce. The seminal moment for me came when we were shopping together and he bought his belt in the children's section. And at that moment, I realized Brian wasn't doing anything special. His biology preserved him from doing what would work, what would happen to me or to my family and so forth. As a bariatric surgeon, having started here in 2002, we see a lot of really good results. There are a lot of data about GLP-1 and other gut hormones in bariatric surgery. And so we're talking about the medications sort of recapitulating the type of success that we've sort of seen, at least is the way that we think about it. So a little bit about bariatric surgery, and I won't get too far into it, but if you look at total body weight loss, we're talking about, a quarter or so. Lots of good data on diabetes remission, especially with gastric bypass and duodenal switch. And so it's reasonable to think, okay, this is the benchmark of all of the tools that we have today. This may be the benchmark that we're going to look at. And when you look at it, here are the different types of therapies that you might see. And when you look at kind of the non-surgical methods combined with surgery, you begin to get the idea that maybe we're talking about complementary therapies, and I'll get back to that in a second. When you look at semaglutide as the one medication that we're using sort of a lot clinically, the data are really quite good. I mean, you're looking at patients who clearly, in very, very good studies, demonstrate weight loss. And I won't belabor this point because I think this is old material, but it's just to set the table. And in the teenage group, in the younger patients, which is a really challenging group of patients to work with, it also is quite effective. And you balance that against the fact that we see a lot of side effects from the patients, right? So we'll talk a little bit about some of the GI side effects in a minute. Gallstone formation, probably a product of rapid weight loss. So I don't necessarily lump that into anything that's unique to the GLP-1 receptor agonists. But if you look at, some of the multi-agonists now, you sort of look at, Tirzepatide. We know that Tirzepatide has good action. We know that it is sort of in a dose-related fashion, kind of goes to some of the information that Sean mentioned. We also know that a lot of the patients get a really, really good result. Okay? So when you look at comparing these medications, I mean, there are really good data that if you deal with more than one target, well, you're going to get better results. that again goes to the last talk, which is there's all this stuff that's happening. And, the more you can get at different things, the better results that you have. Kind of makes sense. Probably not that simple, I would imagine. I think there are going to be things where when we mess with them, it's going to give us the opposite results. But I think at least at this moment in time, that probably holds true. Okay. We talked about some of the agents now that are going to be sort of finding more and more targets. I think if I want you to hear one thing from me today, it's the durability. And that's going to be the main point of discussion. So let me go through this one by one. So if you look at intolerance, this is a big deal. And we actually think this is the main mechanism by which these medications work. So you hear about the reduction in food noise, and without sort of mentioning the word, Justin described it perfectly well. The patients say that the food noise is quieter. But we think that the majority of the mechanism comes from the effects on the GI tract that was mentioned by Bethany earlier and the delay in gastric emptying. It also, though, is a balance because it's also one of the main reasons that the patients discontinue the medications. The gallbladder disease risk I mentioned a second ago. There are some warnings about intestinal obstruction, and then we're hearing about some of these metabolic things, the sarcopenia and the muscle wasting and so forth. It's interesting that bariatric surgeons, we learned a long time ago that if a patient is limiting their intake, you not only have to worry about what the volume is, but you have to worry about the content. So probably a lot of this is that the prescriptions that are occurring by people who, for lack of a better word, aren't experts in sort of obesity and in bariatric surgery and so forth, because we tell our patients, protein. You prioritize your protein, and once you hit your protein goal, you can worry about all the other stuff. So my suspicion is that some of what's happening here may just be the fact that the people who are providing the majority of these prescriptions don't have that type of savvy, I would say, about kind of managing patients during rapid weight loss. And then finally, these psychiatric concerns that are coming up. I tell you, there are a bunch of papers out there about psychiatric concerns with bariatric surgery as well. So to me, it's something as a footnote to keep an eye on, but I can't tell you mechanistically why in the world that would be different. But this is sort of where we are today. And when you kind of look at some of these things, they're pretty substantial, right? But what I would say is, so were the first chemotherapy drugs. So were the first antibiotics. So were the first everything. You never hit a home run the first time. It's relatively rare. Okay. And so when we're talking about the durability piece, here's the part that I really want to confer to you all. Discontinuation of the medication results in rapid weight recurrence. To me, this has nothing to do with the medications. It has everything to do with the fact that as bariatric surgeons and weight loss experts, we spent many years trying to convince everyone that obesity is a disease, that it's a chronic disease, and the way that the prescribing habits are occurring outside of specialized centers goes back to the behavioral thing, which is a stigma to patients, right? So if you have a chronic disease, you should never stop treating it. And you can see here, whatever medication you have, anytime that you stop it, the disease comes back. Well, you'd never stop your blood pressure medicine. You'd never stop your insulin for that. You'd never stop anything else, right? So the problem is most of the patients are not able to continue their medications. And so really we talk about this chronic disease model, and then, people talk about surgery versus medications, right? That's completely wrong, right? I have a set of tools at home, and I don't pit my hammer against my screwdriver. I'm like, I love both of you guys, and there's a good opportunity for each of you depending on what I'm doing. So I think we have an opportunity here to drive a complementary approach using the cancer model for therapies. And I would propose to everyone in this room that the fundamental step that's missing right now is that we don't understand the disease well. And to quote my buddy Sean in his talk, we also don't understand how that disease is different in every single person. And that's where the precision nutrition comes in. If we understand this disease at an individual level, we'll be able to tailor therapies with the tools that we have. So, just very quickly, I think when you look at this in terms of the synergies, you'll find that really surgery plus medications right now, we haven't found any data to show that that the current regimens, basically your regular prescribing habits for GLP-1 receptor agonists along with surgery, don't seem to make a difference. But again, there is a lot of room for trials. And if you look at this, the interesting thing is that even if you think about today, there is a role, because in surgical readiness and glycemic control, which improves surgery, they're quite good. Do they change things after surgery? We haven't figured that out yet, but now we're also not talking about patients whose disease is severe enough that they have a recurrence. So I showed you this earlier, and if you look at it, really across all of the operations, we think we can do a better job if we have, combined efficacy of things. So I'm going to just, in the interest of time, just move forward with this, which I think is really important. What happens with weight recurrence? Because surgery is not a panacea. And I think there's a really important role for medications when patients have weight recurrence after surgery. So very quickly with the take-homes, that really we're looking at a first-generation chemotherapy is kind of how I think about it in the neoadjuvant and adjuvant setting. I think we have to be able to get our patients to stay on the medications better. We have to have medications with better side effect profiles. Weight recurrence with the medications and with surgery underscores that obesity is a chronic disease and not a behavioral issue. And if I had to guess about the future, I would say that we're going to have just an increasing set of arrows in our quiver to be able to get at how we treat a disease in a specific individual, but we have to understand the biology of the disease on a patient-by-patient basis better. Thank you.